Okay, so this is our case report, differential diagnosis and physical therapy evaluation of thigh pain in an adolescent boy. And that's for differential diagnosis class. The patient history. The patient was a 14-year-old boy presenting with thigh pain that began 3 weeks prior to evaluation while playing basketball. His first contact with a health professional was a physical therapist, and since onset, the boy has played basketball twice and reported having a limp after each session. The patient revealed that he had similar pain about a year ago that resolved itself. His primary complaints include he can't run or climb stairs without pain, and pain is restricting his recreational activity participation. So in patient presentation and observation, the patient had an antalgic gait when entering the therapy evaluation, kind of avoiding that leg. Left lower extremity was maintained in an externally rotated position during gait, and his pain scale was 0 to 10 at rest, 2 to 3 when ambulating, and 5 out of 10 when participating in sports. So in the examination, the PT found in the functional and the ROM assessment that he had no limitation in pain in the lumbar spine with active and passive range of motion. His hip limitation and capsular pattern was found, flexion, abduction, and internal rotation. He had a passive straight leg raise that was painless with no restriction, and he had no limitation in extension or external rotation of the hip. In a manual muscle test assessment, hip flexion was strong but painful in a seated position. His hip abduction and supine was painless and with noted weakness on the left lower extremity hip abductors. So his full evaluation for strength was limited due to testing or discomfort in testing positions, which means he couldn't really lay sideline on top of it. So special testing, a Favors test was performed with positive pain felt in the trochanteric region. So differential diagnosis of this, it could be a fracture of the hip or femoral neck due to limp and pain due to weight-bearing activity. You could have strain of a hip flexor, abductor, extensor, or adductor musculature, which is possible with strong and painful MMT of musculature, but Cyriac states that muscle strains prevent with non-capsular patterns, so that's eliminated here. Strain of the hip capsular ligaments, it definitely could have happened, and due to the capsular pattern restriction, it's kind of indicated there. You could have bursitis of the greater trochanter due to possible pain on palpation of the hip and greater trochanter, and an inability to position for MMT exams. And since he's a younger male, which is a high probability, he might have slipped capital femoral epiphysis, SCFE for short. And the patient history and epidemiology of SCFE indicates the possibility of this condition. So in assessment, the physical therapist determined that the evaluation of the hip joint, or through the evaluation, that the hip joint was the source of the pain or source of the limitation. And utilizing the patient history, observation, and examination findings, physical therapists determined that the lateral thigh pain of this patient was beyond the scope of practice for PT, and referred the patient immediately due to possible slip capital femoral epiphysis. The patient was consulted by an orthopedic surgeon, and radiographs were taken, which confirmed the diagnosis of SCFE. SCFE, by definition, is a fracture of the femur below the epiphysis, which causes a gap or a slip between the growth plate and the proximal portion of the femur. It's considered an emergency situation due to the likelihood of secondary conditions, avascular necrosis, and chondrolysis of the femoral head resulting from this condition. The epidemiology of this condition typically occurs between the ages of 10 and 16. It's more than twice as likely to occur in boys. Other factors are 50% of the patients are obese, which wasn't indicated here, and 37% have bilateral symptoms, which also wasn't indicated here either. So in treatment of this, immediate elimination of weight-bearing activity and referral to primary care is indicated, which was performed by the PT. Surgical intervention is a primary treatment for this condition. The surgical intervention is there to reverse the slip, which to do that, they fixate the femur on the epiphysis via pinning or screws. They normally do it in a singular pin or a screw, and sometimes they use 2 screws, but there's been an incidence of avascular necrosis or chondrolysis with 2 screws. So in summary, the PT evaluation in combination with the observation interview process enabled the PT to find a red flag sign and refer the patient out quickly. Importantly for this, the diagnosis was made immediately after imaging, and they were scheduled for surgical intervention right after the PT evaluation. Delays in diagnosis for this condition can result in major complications for the patient. Proper evaluation screening and differential diagnosing skills are important for the PT to maintain the standards of practice, especially when it comes to special conditions like these. And there's a reference. Thank you very much.